from the online learning experience to making sure all the lecturers and staff have the knowledge and tools to do it too. It wasn't easy, but slowly and surely we are getting the hang of it, inshallah. Okay, and then the institution, UKM, had also made sure that there is going to be a formal online platform for the teaching and learning activities. So at the get-go, UKM had made sure the online Moodle learning management system called UKM Folio is fully set up for any synchronous or asynchronous teaching and learning activities, and MS Team as the formal online platform for teaching, meeting, discussion, etc. Now, getting back to the pandemic challenge, one of the most important challenges in online teaching currently right now is to engage students or learners. It still has to be active, it still has to be interactive, and not just one-way teaching, me talking to the screen. Since we cannot see all the students in that one particular session, it is not just that we do not want them to be left out, we also want their undivided attention and understanding in our lecture session. And since Prof. Azran is hailed by the London Speaker Bureau as the global, I have to bring this up, global top 10 most booked speakers in 2019 and #1, numero uno in Asia, we are pretty sure that you have plenty more up your sleeve. And we are also confident that Prof. Azran Osman Rani is the person for this topic, as he had shown his credibility and master skill in his first online webinar with us in January 2021, where you actually talked about your book and also your talk on 30 days and 30 years, resilience and agility for 2021. We were truly captivated and we were in awe, jaw-dropping, yeah, with his inspiring life stories and motivating speech. So we would like this afternoon for everyone who is joining to pick Prof. Azman's brain to learn the secrets of his trade, trip and tools to engage audience in online public speaking during pandemic. Before we can carry on, I have a few favors to ask from all of our participants. If you can have yourself mute, and if you have any burning questions or inquiries during the session, please put them in the chat box, and I shall read them to Prof. Azran after his task. Okay, so without further ado, Prof. Azran, the digital online floor is yours.
Oh, wow. Thank you very much. I'm so honored to be here. Assalamualaikum, everyone. It's great to be back. I'm still learning what adjunct professor means. I don't know. And I may or may not have anything up my sleeves, but clearly nothing here. So as I kick off, please feel free to use the chat to type any early questions you might want, anything you'd like to get out of today's sessions, either questions, comments, because the more feedback I get from you, the more I can tailor the message today for you. But for the brave ones who turn on your camera, I see Norfara, Munira, hi again, Shanita, Siti Sarah, Rosita, thank you so much for turning on your camera. I know, for example, Shiping says, oh, I really want to, tapi tak ada webcam, but that's okay. Faisal, thank you very much for being and connecting with me today. So what I wanted to share with you is not necessarily just about online learning platforms, although I can talk about what I'm doing in terms of building e-learning curriculum or courses. But at the heart of it, it's our role as a communicator, our role as a storyteller. How can we engage someone with our presentations? And this message applies whether they are online, like we're doing right now, or even when we go back to having live presentations and lectures. And especially in clinical topics, right, that is very research and data heavy, right? Because how do we convey these very technical substance into a story that's going to connect with our audience? Because that is the goal. Because if we just simply present data, but it's not really absorbed to the point where people retain, then we've not really achieved our objective of imparting knowledge and sharing experiences. So to start with, I want to ask you what your thoughts on the chat is, what you think of all the different things and challenges in terms of giving presentations online or in person. What's the number one biggest presentation mistake? Let me know on the chat if any of you have ideas on what you see as the biggest presentation mistake. Wordy slides, okay, very good one. One-way communication, reading slides, uninteractive, monotonous, dull, and losing the audience interest. Unprepared, uh-oh, maybe you might catch me being unprepared. No eye contact, and that is why, if you can turn on that camera, I can look at you. But thank you very much. And you're right, because in a way they're interrelated. Sometimes when we have too much text and numbers on the presentation slides, we inevitably latch onto it and we start to read our slides rather than connecting with the audience, right? And it's not uncommon when you think about technical presentations and clinical presentations to have slides that look like this. If any of you use slides that look like this, and you have the courage to say, yeah, me, put up your hand. So actually, the root of it, the one thing that I want to share with you is this. The single biggest presentation mistake we make, right? The real root is we try to combine slides that we put in a report and we are trying to present that slide. That is the biggest mistake. A report is a document that we prepare that is a standalone document that when someone gets the report, they have all the information that they need, right? So that is why we want to make sure that, we put in all the bullet points to explain what the data says. That is why we want to make sure we have our sources and our footnotes in place, because we know those are the questions that a reader will want to know when they look at our slides. So we design these, landscape slides or analysis for our standalone reports, but the mistake is we use that same design for a presentation. Presentations and reports are two different things, right? When you try to combine those two, that is the number one issue. Because the moment you put up a slide like this, guess what happens? Your audience will start to read your slides. And when they're reading your slides, they're not listening to you. Because humans, we only have one thing that we can focus on. And when you lose control of your audience, you're going to lose control of your presentation. Especially if suddenly they already have the presentation slides in front of them. Guess what's going to happen? They're going to start flipping and being 5-10 slides ahead of you, right? So it's very important for us to understand that as a presenter, it's our job to control the message that each of our audience members are receiving. Now, I put up this slide because even with my team in Naluri, right, we have these dense slides that we produce, but these are report slides, right? When we want to, for example, share it with our board members, share it with our investors, share it with our business partners, it needs to have, very detailed, numerical graphical presentations, the key takeaways summarized in bullet points, and the source of footnotes in place. But if I were to present something like this, I need to make sure that the essence stays. And so what I would do is to basically think of the slide as a backdrop, right? Because the audience needs to focus on you. You are the main content, not your slide, right? And if there's a clear message, it needs to be conveyed in just very, very few words. And if there's data, what you want to do is just think about the simplest way of presenting that data, right? Because you have to be the one telling the story. You set the pace and the narrative, not your slide, right? And when you have a slide like this, you're less likely to keep looking at it and make the mistake of trying to read the bullet points on your slide. So how do we reconcile between reports and slides, right? And one way that I found very useful is when I give my reports, I use PowerPoint notes format, where the slides that I will use to present can be there, as you can see here, but any details, for example, tables, more detailed analysis, bullet point sources can be put in the notes section. And so then I can compile that as a vertical report. This becomes a report that's easier to submit to readers who need it as a standalone document. But if you're going to present this, you would only visually present the high-level slide so that you control the content, right? So that's kind of how you don't have to necessarily avoid doing two things completely. But if you do only try to present dense slides, that is probably the single biggest issue that I've seen happen. So when it comes to designing our visuals, right, the test that I go with is the billboard test. And the billboard test basically says that, a driver driving through on the road and seeing a billboard will have at the most 2 to 3 seconds to see the visual before they're going to drive past. And so can your message be captured in 2 to 3 seconds, right? That's the test. Even though you're going to actually spend maybe a few minutes talking about the slide, but the visual itself must be as simple as being able to convey the essence of it. Not every single detail, but the essence of it. And that's why visuals can play an important part, right? Like literally 1 second, I see the sundae from McDonald's and I'm already evoking a desire to want to stop at the next McDonald's and order a sundae. And the general rule of thumb when it comes to billboards is, really big fonts, but, not more than 5 to 7 words so that people can just grab the key message as they pass. Now, even in the world of billboards, not everybody practices this because you can see in KL, in many places, you have a proliferation of these billboards that look something like this. So this is kind of the equivalent of that, standalone report slide where you're trying to put in all the small font, size 10, size 12 font, because you want it to be complete. But if you were driving past this sign, realistically, are you going to read any of this? You're not. And when you see clutter, it becomes, cognitive overload, and you're going to kind of miss on what am I supposed to take away from this message, right? So how we design our visuals sets the context, because you want visuals that grab the audience's attention. You want to connect emotionally first, and then they're going to be more receptive to the content and the facts and the data that you're going to be sharing. So, another example, just to illustrate the power of visuals to communicate your idea, right? So if you look at this simple chart of a biopsychosocial model of health, right, where there's a lot that you want to convey, if you were to present something like this, your audience will likely just kind of zone in and try to read every single word, right? Whether it is, how does this apply to diabetes? How does this apply to COVID-19? But instead, if we were to use powerful and impactful visuals, right? And guide people in terms of talking about the biological impact, talking about the psychological impact, talking about the social impact, right? And how would it apply to diabetes, or how would it apply to COVID-19, right? The biological aspects, the psychological aspects, and the social aspects. So visuals, hopefully, I've given you a flavor of how, powerful visuals can kind of create the emotional connection that will help listeners gravitate towards the message that you want to tell. But actually, as we want to prepare to be the best presenters, nothing beats the experience of giving a whole presentation without any slides. To me, this is the real test. Because if you can convey your message, even if it's a full 1 hour lecture without any slides, you force yourself to visually articulate the message. And that means your audience is likely to be able to capture it more, and you are also more likely to get straight to the point. So this for me is a good practice. I try to do as many of these as I can, where I'm giving a presentation without any slides at all, because distilling the message is so crucial. And how do I try to get better at, trying to simplify the message and the story so that my audience can connect with it? And my very, very, technical analysis is what I call the Mamak test. And so no matter how technical your clinical presentation is, the challenge is, if you were to present it to your friends at a Mamak restaurant over a meal and drinks, you will by nature impulsively or intuitively start to summarize and distill the points, because clearly they're not going to go into the mood of asking you about your footnotes and your data and all of that, right? But you've got to be able to articulate it to grab their attention, because you're competing for their attention against that delicious looking roti canai and murtabak, right? And so applying this test means before that big presentation that you might be coming up, highly encourage you. Although I know Prof. Susanna will say, okay, Azran, maybe not that kind of food. We want to practice healthier eating. So maybe take them to a healthy eating restaurant, but try to share with your friends the message that you want to tell to other colleagues, other research professionals or students, but deliver it in a way that makes sense to someone who's sharing a meal over you. That's helped me distill the main messages to really craft, the story to connect with someone. So that's kind of my one takeaway. So if I were to kind of summarize how I think about putting together a presentation, here are 4 things that I try to keep in mind. The first, right, at that opening of your presentation, to have what I call a mind grenade. It could be something as simple as, what do you think is the biggest presentation mistake? We did that, right? Because it draws your audience in. Oh, I'm responding. And especially in an online webinar setting, the more you can get people to type, the more they're engaging with it. And so if you can open your presentation with a mind grenade that grabs people's attention, you're less likely to lose them immediately. The second thing I try to focus on is to have what I call a humanizing anecdote. And this is much more crucial in clinical presentations, because, as much as academics think, yes, it's just about facts and data and logic, but in a presentation format, in a proper lecture, we are first and foremost humans before we are academics. And we need stories that kind of really help our listeners or our audience remember the key message. And I guarantee you most people will remember powerful stories much more than they will remember data. Because remember, you can always follow up later with that detailed report with the tables and the footnotes and all of that. But during the presentation, you want to be able to use humanizing stories and anecdotes to build that emotional connection first. And only then that I talk about first really focusing on describing the current challenge and your solution, but using words that allow people to imagine as if they are there with you, experiencing that challenge and then looking at the solutions that you've built to address those challenges. So I'm going to try to give some examples in terms of each of these 4 steps, as I even share with you a presentation on what I do today with Naluri and our digital health program. So 4 simple things as a takeaway. But first, people ask me, well, are there examples, good examples that we can follow? And so I'm going to share a few. You can definitely get on YouTube or Google. And if you were to Google Dr. Eric Topol's TED Talk, The Wireless Future of Medicine, he starts with this mind grenade, right? Which is, what year do you think the stethoscope was invented? So if any of you know the answer, or you just want to guess, just for fun, let's type on the chat, what year? What year was the stethoscope invented? Anyone? 1945, Farah, thank you. Najwa, 1800. Ooh, okay, big difference. Anyone else? 1920, Dr. Linda has actually Googled because she got it right. 1816. How many years ago is 1816? Okay, let's test your math. 1816, how many years ago was that? Okay, let's see. All right, awesome. All right, I love Hannes's approach, which is the best, which is basically, as long as it's within, less than a 5% tolerance, that's kind of good enough in terms of practical terms. So fantastic. Thank you, everyone. And his main point is, there are not many things that we use today in our daily lives that was invented over 200 years ago. Right? Not cars, not planes, even things that we still remember when we were alive, like fax machines we don't use anymore, right? But a stethoscope is in essence a device that hardly has changed, which is just kind of listening to the sound. And so his core presentation was actually, of course, new devices, right? Wireless devices that can measure so many things, your heart rate variability and all these things. But if he jumped straight into that, right, it's going to be a very dry presentation. So he engaged the audience by getting people to kind of think about, what year was the stethoscope invented? Another TED Talk example, again, you can Google or go on YouTube to find this, which I thought was an interesting example of a mind grenade. And this is Dr. David Agus's presentation in 2009 on a new strategy in the war for cancer. And he opened with this mind grenade, which is, when you compare cancer to just about any other chronic diseases, respiratory diseases, cardiovascular diseases, the death rate for cancer over the last 50 years has hardly changed. Whereas in other conditions, humanity and science have made so much advancements that we've brought down the death rate by 80 to 90%. And yet cancer, after 50 years and billions of funding and so much effort, the death rate hasn't changed much. Wow, right? So kind of a mind grenade that grabs someone's attention. Again, what he was focusing on in terms of the substance, is a very technical topic, but he wanted to open it up with a thought starter to grab his audience's attention. Another one, and this time, remember what I talked about, step number 2, which is a humanizing anecdote. So if you went to Dr. Chuck Murray's TED Talk presentation from 2018, right? It's a very technical presentation on, can we regenerate heart muscles with stem cells? But he actually starts with a story of a 70-year-old woman named Donna, who was a heart disease patient. And Donna was a lively and active grandmother. But suddenly, she experienced a myocardial infarction or heart attack, and she was bedridden for 2 weeks. All right. But on that, at that 2 weeks when she was at home, suddenly one of her granddaughters came to visit her and actually found her that she had passed away. And then Dr. Chuck said, Donna wasn't just my patient, Donna was also my mother. And that powerful story, you can imagine people immediately lean forward to listen to what he had to say. His topic is actually, again, very dry, right? Almost talking about 20 years of research that actually didn't make much progress until after 20 years. But he opened up with a personal story that built that emotive connection with his audience, right? So simple stories. Now, some clinicians might say, look, I don't have a story in my personal life, and that's okay. We actually have many, many patient stories. You don't need to use their real names, but distilling a condition into real humans can make a big difference in building that bond with our audience. So to put into practice, right, just to kind of, let's all put into action, I want to tell you a little bit about what I'm doing with Nullery. And the mind grenade that I might start with, when I put a slide like this, you can imagine people go, okay, tell me more, right? What is this guy going to talk about? And I start by talking about how today, even with COVID-19, more people around the world, right, die from diabetes, which is a completely preventable lifestyle disease, than all of the infectious diseases combined, right? Whether it's COVID-19 to malaria, to dengue, to Ebola, and, AIDS, more people die from diabetes than all the infectious diseases combined. More people die from suicide than all of wars, murders, and terrorism combined, even in Malaysia, and certainly around the world. And while many people are dealing with these two crises of humanity, not as many are trying to tackle this together to understand that there is actually very close effects or links between diabetes and depression, between anxiety and heart diseases. And it's time that we need to look at health in a much more holistic and integrated way. So that was my kind of mind grenade to kind of, before I even talk about Nullery and all the technical things, I'll show you all the boring technical things that I do, but I wanted to kind of open up with an important story. And the reason why I started Nullery was because over 9 years ago, almost 10 years ago now, I lost my father to both diabetes and cancer. And as I now recall that journey in his last final years, I noticed that the healthcare professionals were primarily focused on his physical health, right? This medication, this surgery, this chemo, this radiotherapy, this insulin. But someone going through a chronic condition gets overwhelmed with what today we now know as depression and anxiety. And there was no means of providing care because, most of healthcare then, when it comes to mental health was looked at in isolation rather than a core part of helping someone deal with and cope with chronic diseases. Right. And that's why, I felt very strongly about trying to tackle chronic disease and mental health together, because more, when you do look at it from the numbers point of view, there is definitely a clear correlation, right? Because those with diabetes and heart diseases and cancer are 3 times more likely to experience mood disorders, right? And yet, when it comes to the healthcare system, there are structural problems that make it hard to address these things together. First, healthcare, by and large, is still reactive and transactional. It's reactive means we wait for patients to develop a condition and then come to see us. Whether in a hospital or clinic, or even today with a telemedicine platform, it's the same thing. You sit there and you wait for people to come to you. And secondly, it's transactional, meaning it is a single consultation, a single prescription or treatment. But these chronic conditions, diabetes, heart diseases, cancer, depression, anxiety, cannot be treated and fixed with a single consultation, prescription, or treatment. It needs structured ongoing care, right? But the delivery of healthcare is not designed efficiently for a more programmatic approach. And secondly, as our knowledge goes deeper and deeper in healthcare, we have become very siloed by our specialization. So if you went to see a cardiologist, she's likely going to very focus on your heart conditions. If you see a gastroenterologist, he's going to focus on your gut health. If you see a dietitian, she might be talking to you about what you eat, and a psychologist focuses on your mental health. But with chronic conditions, as we alluded to earlier, they're deeply interrelated. And so, we feel that we need to reimagine a model of healthcare that goes beyond siloed specialists to truly coordinated multidisciplinary care teams where the patient is in the center and teams are working together as a single unified unit to help the patients achieve real meaningful health improvements through a structured program. And lastly, a lot of healthcare today is still activity-based. And this is what's causing a lot of frustrations to people who have to pay for healthcare. That would be insurance companies, corporate employers, governments, and to an extent also individual consumers, because the healthcare providers are charging fees for a service, right? Per consultation, per prescription, per treatment, but not necessarily whether you actually get healthy or not. And that is a structural problem in this industry. So imagine if we could somehow challenge that model where we would deliver care on an outcomes-based basis. And that will fundamentally change that dynamic between payers of healthcare and providers of healthcare. And so in order for us to do that, right, we wanted to make sure that we really look at healthcare outcomes as the end product rather than the actual program or treatment or prescription, right? And that these outcomes are clinically significant, right? So when people enroll in the Nullary program, we want to have clear baselines at the start of the program, and we want to have clear end states at the end of the program. And can we achieve comparable clinical outcomes delivered online in a much more efficient way compared to if they had to keep going for inpatient treatments or sessions. And of course, interestingly, the same people who have elevated levels of depression, anxiety, and stress, unsurprisingly, when you measure their blood sugar and their weight and their cholesterol and blood pressure, they also have similar prevalence of elevated metabolic risks. And as we improve that depression, anxiety, stress, we see improvements in their blood sugar, weight, cholesterol, and blood pressure. So we wanted to take an outcomes or results-based approach as a way to fundamentally change healthcare. But more than just numbers, at the end of the day, we exist because we really want to play our small part to transform people's lives. Because beyond just numerical improvements, when you can, help people really take control of their lives, right, through improved mindsets and motivations and self-confidence and self-reliance, we really can change their lives for the better. And that is my number one motivation why we wanted to start Nullary. At the end of the day, it's about the human lives that we can make a difference. How do we do that? Well, as I said, one model is to kind of really put together multidisciplinary teams to work as one, right? Where your own psychologist, your own dietitian, your doctors, your pharmacists, your fitness coach, but we even added executive coaches and financial planners because they're the number one and number two causes of stress. If you can't solve those two causes of stress, good luck trying to get someone to eat healthier. But by delivering it online through chat, we make it a lot more efficient. So you don't need appointments. You don't need to kind of be coordinated in a synchronous manner. We also use peer support groups. So one of those chat channels is if we find people who have similar conditions or similar challenges, we put them in a group of say 7, 8, or 9 people and create gamification elements to track their activities so that they can support each other, plus introduce some competition. They're much more likely to stick to their programs. Now, if it was just chat, you don't need a Nullary app, right? Because WhatsApp would be so much more convenient and available. But if, I'm sure some of the dietitians are trying to provide consultations to their clients using WhatsApp and asking them to post pictures of their meals on WhatsApp. But then you have to explain a lot of things over and over again to the same dozens and dozens of patients. You've got to ask the same set of questions. So what we did was we applied e-learning into mini bite-sized modules of like 5 minutes to 10 minutes that the health coach can assign to the user. So for example, if at the start of the program, the psychologist wants to know what are the stress triggers in your life, they can say, Susanna, when you've got 5 minutes later during the day, why don't you do module 4 on stress triggers, so that, you read about it, you're answering a standard set of questions, and then I, as your psychologist, can review your answers and come back to you in a more focused and targeted manner. And so you're no longer taking up my time, you're doing it at a more convenient time. Plus now, if 10,000 people are answering that same module questions, we now have a much more structured data set where the computer can now analyze those responses and provide unique real-time insights to the professional in a way that the professional might not be able to do only on their own. In addition to that, with psychological support, essentially we've digitized cognitive behavior therapy into a simple thought journal using emoticons so that we can start to look for patterns and clusters, right? Either anger, 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 sadness, 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 or fear, 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 so that the psychologist can then drill down and help them refine what are those underlying issues that they're going through. Next, dietitians use a photo-based food journal. And again, the difference from just posting a picture on WhatsApp and having an individual dietitian look at it is to apply AI visual algorithms to automatically identify, oh, that picture is a roti canai versus a chapati versus a thosai, and then to be able to provide a simple red, yellow, green rating. Because from our experience, if we try to talk to people about calories or exchanges or macronutrients, 90% of people go way too much information. But if I can just summarize it in red, yellow, green, and you can see here the trend of their mix of red, yellow, green, and how do I make better choices, they can start to feel more empowered. So it's not about telling them you cannot eat nasi lemak anymore, but maybe once a week instead of every single morning. Other things that we do are planners, right? So whatever you work with your coaches, whether it is, I'm going to start going for walks in the morning, or I'm going to start to take my medication properly, I'm going to, do mindfulness exercises, whatever it is, key it in the planner, and the app sends you reminder notifications. And you can say, yes, I did it, or no, I didn't. And then the coaches can then monitor you to see over time, are you achieving 50% of the things that you said you're going to do, or is it 80%? And then let's dig in terms of what's holding you back from improving that further. Lastly, we do connect with some, monitoring devices. So instead of just blood tests at the start and the end of the program, we have Bluetooth connected weighing scales. You can connect it with your Apple Watch or Google Fit or glucometers and blood pressure cuffs, so that they're intermediate signals that the coaches can help you monitor over the course of this typically 4-month or 16-week program. But the reason why we do that, right? All the things that I showed you, those 6 features, that's the front end where the user or the patient interacts with the coaches. But on the back end, what we do is we take all that information and we build behavior change prediction models to be able to quantify constructs like mindsets and resilience and motivations in a way that was previously very, very subjective. So for example, this is an actual, one of the men that I showed you in terms of the lives that we transformed, this was his actual 16-week journey. And you can actually see that his readiness to change score is not linear, right? He starts being motivated, but he's going to hit a roadblock or obstacle, he's going to go down. As a coach, I know I want to spend disproportionate amount of time and attention on this person to help him turn around and become more self-motivated again. Then I can back off. I don't need to spend as much time with him. He's doing his modules, he's doing his exercises on his own. But if he hits another roadblock, that's where I can zone in and come back again in a much more targeted manner. By applying natural language processing to understand human emotion sentiments and quantifying them, we can also look out for certain points when people suddenly feel extremely depressed, right? Bouts of depression and anxiety, that as we get better at predicting these things, psychologists can then proactively reach out to people. This is an actual 32-year-old Malay woman who, initially was just talking about diet and exercise, and suddenly her score dropped from subtle changes to her verbs, nouns, adjectives, and phrases that her psychologist, Darlena, reached out to her and said, what's going on now? And she goes, thank you very much for reaching out to me. Husband's been traveling a lot. I'm stuck home with the kids, no support system. Kids are sick, pressure from work. Boy, boss is on my case. A performance appraisal. I don't know what to do, feeling overwhelmed, thinking of ending my life. So an actual suicide ideation. And she wasn't reaching out for help. So traditional reactive models where you expect, employees or patients to pick up the phone and call befrienders doesn't really work, because what we know is that only about 2% of people call when between 30 to 40% of people are experiencing elevated levels of depression and anxiety. So in a nutshell, what I want to share with you that is to kind of give you a live example of that opening mind grenade to grab someone's attention, using a humanizing anecdote so that people feel that, they're emotionally investing into your presentation or your lecture, sharing the current challenges in a way that people go, yeah, I can relate to those challenges, and then presenting the solutions or the results. So that in a nutshell was just kind of a simple set of takeaways as you think about, how you want to present your content to your audience. Last, I'm just going to quickly go through this part because I'm quite excited because like you with the COVID-19 pandemic, we've had to kind of create a lot more e-learning content. So for me, it wasn't just about using the learning management system. That's one part of it, but it was important to add other elements as part of that, right? So for example, we built a curriculum or an e-learning course on resilience, which has 4 main things: the digital modules themselves, specific individual activities, right? At the end of each week of a 6-week course, that there were things that the learner had to do, but then using the Nullery app for personalized digital coaching from the psychologist or the executive coach to check on the answers that the user had filled in the e-learning course. And then every week, a quick webinar recap of the main points, plus team breakout sessions so that people are interacting with peers and sharing what they're learning through that journey. So this was basically a 6 weeks curriculum where we had an initial introduction module. We quantified their resilience level using a simple resilience assessment score. And then we did it at the end so that we have a pre and post point of measurement, but kind of, simple content that can take only about an hour to complete each week, or you can try to do all over a single week. That's also possible. But very important when we think about e-learning modules is to make sure that the interface works just as well on a mobile as it does on a desktop. Because when we can create interactive elements using very short videos, so instead of a 30-minute lecture video, we broke it up into 3 to 5 minute bite-sized videos so that people can watch it on their own time, interactive exercises and quizzes, and also a lot of the powerful and impactful visual imagery and sort of inspiring quotes along that journey. As I shared earlier, for us, tracking participation progress and effectiveness is important. So in this case, there was the outcomes pre and post, the behaviors, tracking the app metrics, usage of modules, time spent online, and then the learning exercises that they filled up as a way of being able to synthesize the effectiveness of this e-learning course. So if that's something that you would like to discuss in this next phase as we move to the Q&A, I look forward to that. But with that, I'm going to thank you very much for your kind patience and attention, and look forward to your questions, comments, criticisms, and I would love to keep improving myself in this journey. So thank you very much.
Thank you, Prof. Azran. Let me have a look at the chat box if there is any question. Okay, there isn't any question. Probably I can start off. You've talked about depression, anxiety, and stress. Due to this global pandemic and online teaching and learning activities, and we just got out from the exam meeting yesterday and for the past week, we could actually see that a few students are actually suffering from anxiety and also depression due to this pandemic and also online learning. So in your personal opinion, is there any ways that during teaching and learning activities we can try to motivate them, or how do we want these online teaching learning activities to be not stressful for them? Do you have any personal idea?
Well, I guess I mean while we can talk a lot about a lot of things, the one message for me which I shared I think in my first webinar was the whole power of social connectedness. Where that depression and anxiety gets worse is when people feel lonely and isolated. So how do we create moments of interaction? And that is why those peer support groups matter a lot, the breakout sessions. So instead of just a one-way webinar, right? Zoom, for example, has a feature where you can then break it up so that people are in groups of 6 or 8. They're much more likely to talk rather than if there's 80 of them listening to one lecture. So maybe instead of a 45-minute lecture, I would try to break it up to only 25 minutes and then take 15 minutes where people are broken up into individual groups. Because when we can help build connections where people can feel like, oh, other people are going through what I'm going through, it's going to feel less overwhelming than that. But more important than all of that is to be kind of tracking that level of emotion so that if we see those signs and symptoms, how can we proactively reach out and provide professional support and care? And I guess the beauty of the Faculty of Health Sciences is you have your own clinical psychologists available.
Connection is very important, although
Yes.
it's online.
Mm-hmm.
Um, we have one question from Muhaini. If the
Mm.
client shows low score on readiness to change, how you overcome it, and how long will the next appointment?
Yeah, so that's a very good point. And by the way, we're still learning about this. What we try to do is do an initial estimate of the readiness to change right up front. And what we've learned is it's very important then if it's sort of below a pretty high readiness to change is to have a proper one-on-one video session because building that empathetic connection, that therapeutic relationship is so important. And once someone can connect with them in terms of like what's important to their life at this stage and why change in terms of these health goals can be positioned as part of what's important to them, then we stand a better chance at getting them to improve their readiness to change. It's a lot harder to do that by chat. It's a lot harder to do that with self-learning modules. We needed to step in and still do a live video session with someone trained in motivational interviewing.
All right. Have you got any more questions? You've talked about rules and regulation at the beginning of your talk with regards to online session. Say, for example, everybody has to put on their camera.
Yes.
So, any other rules and regulation that we might probably not know of?
Well, sometimes before asking other people or audience to do something, it's very important that we role model it, right? And that means good quality lighting and great audio. Are more likely to create a more inviting experience for our listeners. And something as simple, literally, as making sure that the camera is at the eye level. One of the biggest challenges or people face is when they're using their laptop camera and the laptop is leaning, right? So it's kind of like looking up your nostril. That is not a great visual
No.
connection, right? So lift up, find a way to put a few books below your laptop so that the camera is exactly at the same level as your eye. And ideally natural light, if you've got natural light. So, position yourself in front of a window with natural light, or if not, really make sure that you've got good quality lighting because that can make all the difference. So once we've established that, then it becomes easier for us to invite our audience members to do the same.
Cool. Okay. We should change something about this. Okay. Any other questions from the participants? You can unmute yourself if you want to say something. We allow you. Kalau tak ada Prof. Azran, it has been a pleasure to us. that you had spent your time to talk about engaging uh, students and learners in online platform. It is a very insightful and very informative presentation. Before we can end the session, can we take a group photo?
Oh, you're gonna have to turn on your camera.
Yes, if everybody can turn on your camera.
Prof. Susanna's got the logo, everything all set up nicely.
Okay, we are waiting for everyone to put on their camera so we can take a good photo of ourselves.
Oh, so nice to see everyone.
Okay, we give one more extra minute to betulkan tudung, betulkan scarf, betulkan kerongsang, pakai lipstick.
So since it can be very hard, I highly recommend this hairstyle because it's a lot more efficient.
Okay, 1, 2, 3. Okay, another one. 1, 2. Cheers.
All good?
All good. Thank you, everybody.
All right. Thank you, everyone.
Okay, we are going to put up the QR scan code if have anyone who hasn't scanned. Okay, thank you, everybody.
You.
Bye.
Bye.
Thank you, Prof. Azran.
Terima kasih.
Thank you, Prof. Bye-bye.
Bye.
Sorry, Daddy.